Okay, so this is going to be just a quick overview of the review sheet for the exam one and two. So a couple of things that are really important on this. We start off with types of consent. So make sure that you have a good understanding of the difference between that express consent, implied consent, and the involuntary consent. Involuntary we usually use for the psych, and this involves the section 12. Implied, usually some sort of altered mental status, but this patient would want us to do whatever it is that we're doing if they were able to reasonably consent to this. And express consent is obviously the ability to consent and all of the reasons that they're able to do so. So then we have negligence. It's built on four main components. We have to have a duty to act, right? In Massachusetts, that's when we're on actual duty, but in other states, you always have a duty to act. So it depends on state law. Then you have to have a breach of that duty. So there has to be some sort of mistake. Either you did something wrong or you didn't do something you were supposed to do, something like this. You have to have injuries to the patient. And then you have to also have the causation effect, meaning and the fourth thing is that the causation, my mistake, led to the injury. So those four things are the negligence. Major components of the cell know kind of what the nucleus is doing, what the ribosomes are doing, and kind of understand where we're getting sort of the ATP production and all of that done. So the mitochondria. Um, Diffusion, facilitated diffusion, osmosis, diffusion at high to low. When we're talking about solutes kind of pushing through something or solvent, some fluid pushing from high concentration to low. Facilitated, you have some sort of mechanism to help with diffusion. We think a good example of this is glucose and how it gets into the cell. It needs insulin to kind of facilitate that process. So usually these are transport proteins. Osmosis, the movement of water and kind of going from high to low. Acidosis and alkalosis. So just understand how these two different sort of things kind of build up in terms of carbon dioxide, its relation to that. Remember, on our breathing, respiratory side, we can control the pH, but we also control that through our renal system. The respiratory system is fast. So when we have an acidotic patient, they're going to breathe faster to kind of blow off that CO2, but their renal system is also going to start to eliminate the molecules, the hydrogen ions, and the bicarbonate ions is what it's going to kind of retain. So it kind of fixes the acidosis. So we have our respiratory and our metabolic acidosis, alkalosis, and the ways that our two systems are going to kind of try to work to fix those. Glucose, insulin, glycogen, and glucagon. It's that balance of how we're going to manage glucose and appropriate glucose for ATP production throughout the body. And so we have our glucose, obviously, is the important sort of piece to building ATP with oxygen. Insulin is going to be how we get that glucose into the cell. Glycogen is really important in breaking, glycogen is the storage of glucose, kind of usually in the liver or in the fat, and then glucagon is what's going to break up these glycogen stores and going to release that back into its form of glucose into the blood so that it can be used. So glycogen is the storage. Glucagon kind of breaks up these and makes it back into its original glucose form. Just know how we kind of create immunity, how our immune system is kind of developed early on with the sort of immune system you get from your mom or the maternal sort of stuff that you get, as well as how your immune system starts to build from there. Order of the steps, just kind of take a look at what's involved in a scene size up, what's involved in a primary assessment, secondary assessment. So the primary assessment is all about life threats, right? So our ABCs, checking neurostatus, and then we get into kind of deciding, is this high or low priority? Is this patient sick or not sick? And then we get into our secondary assessments with the sample of Epicurus T. You have your vital signs, your diagnostics, and that leads to coming to a differential, and then you're going to treat that. FiO2 and oxygen delivery devices. So just think of our non-rebreathers, nasal cannulas. Remember FiO2, fraction of inspired oxygen. So it's just the amount of oxygen that's in the air that a patient is breathing. In the sort of atmospheric air, the air that we're all breathing right now, you're breathing 21%. Different, nasal cannulas can go up into the 40s depending on your flow rate, and non-rebreathers can go up into the 90s depending on, again, your flow rate. Mechanisms of CPAP, just understand how CPAP works, right? It's a positive pressure. So how it kind of is able to, help with especially bronchoconstriction, kind of keeping those bronchioles open, during exhalation so they don't collapse. Also pushing fluid out during pulmonary edema. Understand some of the risks involved with this, what it's going to do to pressures in the thoracic cavity and how that might affect blood pressure. Pharmacological terms, know kind of the difference in, an agonist and antagonist, efficacy, all these different sort of terms that are going to be related to how these drugs work. The pharmacodynamics, really about like mechanisms of how these drugs work within the body, some mechanisms of action. Pharmacokinetics is kind of how these are processed through the body, how these kind of become active, how they get distributed through the body, how they become deactivated and eliminated out of the body. So that's the pharmacokinetic stuff. Med math equations, you'll definitely need to be able to figure out, right? Bolus medications, how much to, milliliters to give for this X amount of milligrams of drug. Also, flow rates and drip rates for your fluid administration as well as drug administration. So, know some of those equations. Types of shock, cardiogenic shock, right? When it's got to do with the heart. It's hypovolemic shock if we're a loss of fluid, whether that's they've bled it out or they've sweated out or something like that, vomit, diarrhea, or it's fluid shifted out of them like burns. Distributive shock, where maybe our blood vessels are super dilated for whatever reason. So we have our anaphylactic, we have our neurogenic, all these types of things. And we and those those types of shocks. Fluid resuscitation, just know kind of what fluids we're going to be using, right? In isotonic solution versus a hypotonic versus a hypertonic. Know the flow, yeah, or like the dosing, quote unquote, the dosing for how you would administer, right? For an adult, 20 mLs per kilogram. It's only when we get down to our neonates, we'll do 10 mLs per kilogram. Reactive airway disease, we're talking about asthma and COPD. So understand kind of the pathophys about, this being down in the bronchioles and in the alveoli. They're reacting, and kind of when we talk about reacting, they're constricting, cutting off airflow. Especially the big problem with the reactive airway disease is getting the air out of the lungs, right? So we get air trapping in both the asthmatic and the COPD patients. So just know the difference in the pathophysiology of asthma versus emphysema versus chronic bronchitis. Pulmonary edema, obviously fluid filling the lungs. This tends to be a heart problem. Can be altitude. There's other reasons why pulmonary edema builds up, but make sure that you kind of have a good understanding of the left-sided heart failure that tends to result in pulmonary edema. Pulmonary embolism, blood clot within the vasculature of the lungs, and kind of understand the signs and symptoms, the presentation of that. Pneumothorax, your collapsing lung due to pressure around it, and kind of know, especially a spontaneous pneumothorax when we think of the medical setting and why that tends to happen, who that tends to happen to. Our coronary arteries, our left coronary artery, our right coronary artery, just kind of think about what they feed, what kind of, what are they delivering the blood to. Cardiac output components. So we have heart rate times stroke volume, and stroke volume is built up of a couple of different things. And so kind of have an idea of how cardiac output is essentially manufactured or built. Types of stroke. So we have our embolisms. This is the sort of ischemic strokes. We have our clots that build up. So our ischemic stroke versus our hemorrhagic stroke. So our ischemic clot, and then hemorrhagic, you have usually an aneurysm that has burst and is now bleeding and leaking into the brain tissues and the spaces around the brain. So understand the different presentations of these, and some of the signs, symptoms, the vital signs, some of the ways that we're going to recognize that. Types of seizures, remember your obviously your grand mal, your tonic-clonic seizures, your sort of classic example with the movement, the jerking movement. But also remember we have some of those other sort of simple seizures, the partial seizures where could be part of the body, right? We have that sort of maybe the finger going. You might have the eye twitching. There's absent seizures where the patient is just completely sort of unresponsive in a sense. They got their eyes open, but they're just not responding to anything. They aren't really having any muscle tremors or any kind of activity, motor activity, but they are seizing. And then we also have the febrile seizures, tends to find that with kids. And so we tend to need to kind of bring that temperature down, and that's usually what is going to resolve that seizure. So know your seizures and types of seizures, how they might present. Types of diabetes. Type 1 is going to be an autoimmune disorder. It tends to not always, but tends to kind of hit earlier in life. And this is where your pancreas just simply doesn't really produce insulin, or at least the insulin that it does produce is just not much, and so is very ineffective. So this is something that they're going to require supplemental insulin for. They're going to have to take either insulin shots, or now becoming a lot more popular is a pump, versus diabetes type 2. Now with type 2, this tends to be due to a high sugar, high fat, low, exercise, high stress sort of lifestyle. But what we've done is essentially overworked the receptors of the cells when it comes to insulin. So they just stop responding to the insulin anywhere near as effectively as it used to. And this means that glucose really doesn't have the ability to get into the cell. It struggles, it stays in the bloodstream. And so these patients tend to be on oral medications, metformin, glipizide, glucophage. These are medications, oral medications that type 2 diabetic can help maintain. Some type 2 diabetics are on insulin, um, but this is something that can be maintained, diet, lifestyle, all this sort of stuff. Hyperglycemia versus hypoglycemia is think about how these two things are going to present. Both can present in altered mental status, both can lead to seizures, both can lead to sort of tachycardia and these types of things. But what we tend to find with these is the hyperglycemics tend to be quite dry, not really sweaty, versus hypoglycemics tend to be really, really sweaty. And this has to do with their hydration status of hyper versus hypoglycemia. So kind of understand some of the major differences in the way you're going to see these present. Allergic reaction versus anaphylaxis, just kind of understand how we define these two things technically. An anaphylactic is an allergic reaction that is involving two or more body systems, and especially from the emergency medicine's viewpoint, that is going to involve the respiratory and the cardiac systems. The vasculature tends to dilate, and the respiratory system sort of is going to constrict in down the bronchioles and in the upper airway. And so we wind up with stridor, wheezing, and low blood pressure. You wind up with hives, all that sort of stuff. And allergic reaction is more localized to wherever the reaction was exposed to, and doesn't tend to spread. So one, we can use sort of an antihistamine like Benadryl. The other, we need an EpiPen. Toxicology is a big chapter. Just remember that ultimately a lot of toxicology boils down to us doing supportive care, trying as best as we can to figure out what the substance is that they ingested or intaked in whatever way whatever way they did. But at the end of the day, it is mostly due to supportive care that we're going to do. The big one that we have the ability to reverse, obviously, is going to be opioids, with our Narcan. Just remember to ventilate your patient before you give the Narcan. Don't have someone that is hypoxic and that is going to wake up and have a big problem. Agitated delirium. When it comes to the behavioral health or the psychiatric chapter, just as all of them are very important, but this is the one that is going to have significant changes in their vital signs. And these patients, they seem to be really just out of it, but they're going to be very tachycardic and be very hypertensive. And these patients can wind up really tiring themselves out and kind of passing out. And these patients actually can wind up dying. This can be fatal. So trying to recognize someone who is just really in a agitated state or a sort of elevated state versus someone who is in the actual medical status of agitated delirium. So these are some of the things to just focus on. This is not meant to be an extensive list. You are responsible for everything that's within these chapters, but this is just to help you kind of guided a little bit in terms of what to look for.